today. And then next week you have an exam. And after the exam, we have the Sonicare person coming. They used to come in person. We used to have a live presentation. They never did bring lunch, but that's okay. You're getting a $100 toothbrush for attending. You do have a little bit of homework. So check out the email that I sent to you as far as what website you're supposed to register at, because you need to be registered there in order to take advantage of the coupon. So what happens is you'll be taking the test from 9 to 10, and then at 10:30 you'll be coming back from 10:30 to 11:30, and logging in. You have a test next week, so I'm assuming many of you will be having a book in front of you instead of paying attention. I'm no judging. But you know what? Sometimes it's better just to have your mind do something else before an exam. But having said that, you need to be logged in order to get your toothbrush. Okay, I am going to be sending a class roster to the company, and then they are going to check your login to make sure that you were there and there for the appropriate amount of time. So if you want a toothbrush, you're just going to have to figure out how to do that. Hint, hint, okay? Because I want you to have your Sonicare, and I want you to use your Sonicare and compare it to your Oral-B to be able to talk to your patients about the differences in them and why are you choosing one over the other. I'm an Oral-B person for my mouth, but do I recommend Sonicare and other brushes to other patients? Absolutely. Depends on what the condition is in their mouth and what kind of movement they like doing with their hand and how big their teeth are. I got these little square chiclets, so the Oral-B fits in my mouth beautifully. Any questions before we get started about Perio? Okay. Any questions about clinic so far? Yay. I hope that the transition this week was fairly smooth for you, getting to know a new partner. Some of you changed units, some of you didn't, and everybody had a different partner. And poor Joanne is working by herself for the first time, so she had some transition to get used to that. And Michaela, who worked by herself last time, is now having a partner. And it all works out. I hope that you're finding that it is more of an advantage to work with a partner than the disadvantages that you might find. But we will talk about strategies too, from transitioning from 142 into 143 with completing patients and not completing patients and that type of stuff.
Misty, I had a question.
Yeah.
Can you hear me? First of all, I'm logged in under my daughter Kaylee, so that's I don't know what that's about. But the other question was, do we still have partners over summer semester?
Yes.
Okay. And is it all fall? Is it the whole next year we're by ourselves, or do we have partners again in the fall?
All by yourself for 244 and 245.
Okay. All right. Thank you.
You're welcome. Now our COVID class is, they just started individual work a few weeks ago. Some of them are completing patients with their partner, but that was because we weren't allowed to have a certain number of people on campus, and they still are wanting us to limit that as much as possible. So we decided to keep you with partners through the summer. When you begin your second year of dental hygiene, you will be solo. If somebody does not have a patient for whatever reason, then maybe you'll get some help. But that's the plan. Second year students, you'll be working by yourself and you'll be well accustomed to it by the time you get out in private practice. So let's get on with the topic at hand. Chapter 21 is periodontal debridement. And guess what? That's what you all are doing every day. We've gone through the assessment portion of things. I did send out an email with a YouTube link that Ms. O'Brien did for the CDT codes to hopefully help with the treatment planning, because there's always confusion with the treatment plan, and that's okay, because not only do they change as far as the CDC codes, but you might have to do this sextant needs, 1 to 3 scaling and root planing versus everything else is scaling with inflammation. So you might have different codes that you're working with. And that's where we come in to just help talk things through, because sometimes there's more than one way to accomplish what you want to accomplish. So periodontal debridement or periodontal debridement is really the way you're supposed to say it is debridement. That's not how I learned it, so I say it the wrong way. But for periodontal disease that it is site specific. If somebody has an 8mm pocket, it can just be a localized 8mm pocket, and everything else can be normal and healthy. So we want to be site specific when we're talking about treating the patient as well. So everything changes and it's different from one patient to the next. So our treatment really needs to be on a patient by patient basis based on our assessment data that we've collected. So we have these flow charts and we have other things to guide us, but what we put for one patient might not be adequate for what we put for another patient. So tissue response is considered a critical factor in determining the success of periodontal therapy. Has the swelling gone down, the edema? Has a long junctional epithelium been formed? So between the reduction of the edema and the long junctional epithelium, hopefully you have a reduction in the pocketing as well as there might be recession that's evident that wasn't there. Was the email, the email was sent yesterday. So periodontal debridement, and I can send it again. Periodontal debridement, okay, that's the initial phase to control supragingival microbial biofilm and to disrupt subgingival gram-negative microbiota. This is to delay the repopulation of those pathogenic microorganisms. So we're trying to convert that diseased biofilm into a healthier biofilm. The origin of subgingival biofilm is the apical extension of growing supragingival biofilm. Okay, so what happens on top of the gum has a direct effect for what's going on underneath the gum. So that's why what we teach our patients to do on a daily basis is so critical. You don't want to minimize the brushing. You don't want to minimize if it's flossing or the proxa brushing or the water jet device, water flossing it's called now instead of water picking, because water pick is the name brand. But you really need to emphasize that each and every appointment that the patient comes in, especially if you're doing periodontal debridement. So that's why you are using disclosing solution each and every time the patient comes in. That's why you are reviewing the plaque index that you get. You were 75% last week. You are 65% this week. That means you've come down 10 points. Woohoo! Celebrate those little victories. Or you were 75 last time and you're still 75 today. However, the quality and quantity of the biofilm has changed. Last week it was all dark purple and very blue and thick, and this week it's showing us that it's a light pink, which means it's been on your teeth for less than 24 hours. So the numbers don't oftentimes reflect really what the patient is doing at home. That's why we have that qualitative statement that you have to add to it. So what starts on top of the gum, all right, then starts cascading underneath the gum line area. So we also want to make sure that we only start what we can complete. Incomplete subgingival instrumentation is not doing the patient any good. All right, it is still a biofilm plaque trap. And as that tissue tightens, because you've removed some of the calculus, that tissue tightens because you've disrupted some of the biofilm that's on top of the calculus that's been left, et cetera, it's going to be more difficult to get your ultrasonic insert and your instruments underneath the gum tissue. And if they've got deep pocketing, you're setting them up for the possibility of a periodontal or lateral abscess. So non-surgical therapy, which is what your periodontal debridement is returning the gingival tissue to a healthy, non-inflamed state that can be maintained easily by the patient and the practitioner. That is part of the definition. All right, so know what non-surgical periodontal therapy is. It's to control the supragingival microbial biofilm and to disrupt subgingival gram-negative microbiota, okay, to delay the repopulation of pathogenic origins and to return the gingiva to a healthy state and maintainable state. Some terminology: scaling. That's the removal of dental plaque, calculus, and stains from the crown and root surfaces. That can be performed both supragingivally and subgingivally. Now, this has the difference between, is it a adult prophylaxis or is it scaling and root planing? Now, root planing is a treatment procedure designed to remove cementum or surface dentin that is rough, impregnated with calculus, or contaminated with toxins or microorganisms, because that root surface is rough. Periodontal ligaments used to be embedded in it. It's now exposed to the oral environment. It might not be supragingival, but it's exposed. Okay, and that roughness is a nice hiding place for bacteria. What we've found over the years is extensive root planing is not needed to obtain healthy tissue. We're trying to remove the bacteria and smooth out the calculus without removing all of the cementum. When I was in school, we were removing all of the cementum, getting and trying to achieve a glass-like root surface. That's not natural. Okay, the gum tissues, those desmosomes, hemidesmosomes, they can't stick to a smooth surface. So microscopically, we're trying to not do that. Now, root debridement is now the preferred method, and that is the removal of a foreign material. Now, that's the biofilm and calculus or dead tissue from the crown root surface. Okay, that's the tooth, but also treating the pocket space, the pocket wall, and bone surface while preserving or conserving the cementum and achieving a good tissue healing response through control of bacterial infection. So periodontal debridement is treating the entire pocket, not just the tooth and the root. So periodontal debridement includes root surfaces, the pocket space, the pocket wall, and underlying tissues. Now, this term was starting to came out in 1980 or 81 because I was still in school, and it was under a lot of debate. The periodontists did not like this term at all because our job was to remove the calculus, and they didn't care about the pocket wall. We weren't into the bacteria as we are now. But scaling and root planing only focuses on the root surfaces. Now, guess what? Insurance hasn't caught up. This was back in the 80s, the early 80s, when we were discussing and bringing up the term of periodontal debridement. That's 40 years ago. And we still don't have a code for that. They're still calling it scaling and root planing. So supragingival debridement, that's supragingival scaling, the removal of plaque and calculus coronal to the gingival margin. This is something that the Dental Association has been trying to get dental assistants to be able to do for years, even when I was in school. That dental assistants should be able to remove supragingival calculus. And you know, we scratch our heads going, well, gee, that doesn't do anybody any good. You have to get underneath the tissue. So subgingival debridement or subgingival scaling, or quote unquote deep scaling, your patients might call it deep scaling, which just makes me cringe. But that's the removal of plaque and calculus apical to the gingival margin. I worked in Perio as a new graduate. I've worked in general practice. I've worked, you know, I've done it all. And when I get a patient that is alternating appointments from a periodontist and the general office, that way they get their scaling every 3 months. You know, they go 3 months here, 3 months there, then 3 months back to us, or vice versa. I've had patients say that the periodontal hygienist says that they're doing a deeper cleaning than what they get at the general office. And that really makes the hair on the back of my neck stand up, because guess what? We're always doing a deep cleaning. And I have to educate the patient that, you know, they don't have, periodontal hygienists don't have any extra education, schooling than we do in general practice. They don't have a separate license. We all have the same license. And we all get down to the base of the pocket, hopefully. So really, they're not doing anything different. We're always scaling to the base of the pocket to the best of our ability. So I really don't want you to use the term deep scaling. Let's get that out of your vocabulary. So we're doing a subgingival debridement, which to me also includes supragingival, right? And we're also de-plaquing. If there isn't any calculus there, we don't need to do a working stroke. And that de-plaquing is the removal of subgingival dental plaque after the completion of periodontal debridement. It's performed at the reevaluation or the supportive periodontal therapy appointments. It's recommended at the reevaluation as well as the maintenance appointments. So we're de-plaquing. If you have an adult prophy coming in, a 1110, no gingivitis, no attachment loss, and no calculus, you're not scaling really, you're de-plaquing. We can use the ultrasonic scaler, and then we can use our hand instruments, but what we're trying to do again, subgingivally, is remove and disrupt that subgingival environment, so it has to start all over again. So we're de-plaquing. You bring the patient back, a perio patient that you're doing quadrant therapy on. You've scaled the maxillary right quadrant, and now you're ready to do the mandibular right quadrant or another quadrant. After you disclose and do your OHE, what you want to do is get your ultrasonic out. If they're a difficulty 3, let's say, getting the ultrasonic out, and you are de-plaquing with the ultrasonic that maxillary right quadrant. You are trying to, again, disrupt that bacteria to allow for healthy recolonization. You're not scaling, you're just flushing out on a very low power. A prophylaxis is prevention of disease. So an adult prophy, a cleaning, is that 1110. We're not going to have a whole lot of patients that fall into that. In private practice, we're classifying almost everybody as an adult prophylaxis, and we're not educating the patient that they have bone loss in this one or two areas. We are treating that area and not billing them for our treatment of scaling and root planing, that one or two areas, and we're not informing the insurance company that they have disease. So we're trying to be more site specific, and that's why they have the scaling and root planing 1 to 3 teeth versus a whole quadrant. Scaling and root planing versus the 43-46, which is the inflammation. That is moderate to severe gingivitis with no attachment loss. You could have that in conjunction with a 43. You've got to mix and match according to what your patient has. Then there's an antibiotic prophylaxis. Antibiotic coverage is necessary before invasive dental procedures that cause bleeding to prevent a bacteremia that ultimately could cause infective endocarditis or serious infections. Infective endocarditis is the heart, but there are other serious infections. If they are immunocompromised for whatever reason, the dentist or physician might want that patient to be pre-medicated. So that's why at school we are so conservative with who we allow not to have a medical clearance. In private practice, if you had a pregnant patient, do you need a medical clearance? No. In private practice, if you had somebody who was a type 1 or even a type 2 diabetic, do you need a medical clearance? No. If they're stable, absolutely not. Right? But at school, you do. So don't take what we're doing at school as the gospel. We're teaching best practice. We're also teaching in an educational facility, which has a slightly different set of rules. In private practice, as long as they aren't dying, they're coming in. And that front desk will say, oh, that's okay. You've got fever blisters. Don't worry about it. Karen will work around it. Well, we don't want the patient to come in with fever blisters or herpetic lesions. We can spread them to other parts of the patient's body, as well as aerosolize that and infect us as well, even with all of our PPE. So oral prophylaxis, that's the removal of plaque, calculus, and stains from the exposed and unexposed surfaces. So a prophylaxis is prevention of disease. Oral prophylaxis is removing everything to maintain health, oral health. We've got polishing. See, these are not new terms for you. Polishing is performed to remove stains from the teeth and has not been shown to have any therapeutic effect. Now, patients are going to be asking you, when are you going to clean my teeth? And you've been working with them for 6 appointments, and you've been scaling them for 4 of them. But when are you going to clean my teeth? They associate the polishing with cleaning. And that, again, is something that we always explain to the patient what we're doing and why. We are cleaning their teeth when we're scaling and doing a root debridement. Polishing is very superficial. It is not therapeutic. It's to remove stains. It's also to help smooth the root surface and sometimes even, the enamel portion of the tooth. So we are using polishing paste that has ACP in it, amorphous calcium phosphate. And as you know from previous lectures, the calcium, and the phosphorus is important for remineralizing tooth surface and root surface. It's important for the uptake of fluoride. So we are really doing a quote unquote therapeutic polishing. We're placing those chemicals, okay, those minerals in the mouth, in the saliva. So then when we afterwards place the fluoride varnish on the teeth, there is more of an uptake of that varnish. Now, are you listing therapeutic polishing in your treatment plan? No, not if it's an adult prophylaxis, okay, or a 1110. If it's scaling and root planing, that does not include polishing. If it's other procedures, you may need to list that separately. But we want to also selectively treat the teeth that have extrinsic stain. This is selective polishing. Having said that, in school, you are going to be disclosed after you polish. The instructor comes over and discloses, or have you disclose, and then we check your polishing. Well, if you've missed biofilm, we mark it. Okay, if it's not a test patient, it's not any points off. I mean, you get credit for the patient for completion. But what we do end up doing is pretty much polishing all the teeth. And that's why we urge you to use the finest prophy paste possible. And by using a fine prophy paste, you're helping to smooth and buff out any rough surfaces. So if you need a medium prophy paste, if you need a coarse prophy paste, think about all the scratches that you're placing onto the cementum and enamel portion. You're scratching it. It's taking sandpaper and scratching. And when you're sanding something, you use the coarse grit first, and then you want to buff. And that's where you go in with your fine paste afterwards. So you never just want to use medium or I'm sorry, coarse. Okay. Offices that you go into are lazy. They want to maximize the time. So hygienists will use coarse paste on everybody. That's not best practice. You're just going to hate the word best practice. You want to customize what paste you're using for what you're being faced with. You might only need to use the coarse paste on a couple teeth, and then you can switch to medium. So use the lightest grit possible. And ideally, by the time you're polishing, you have done OHE, so their plaque index, even if they've come buried in biofilm, is negligible because you've done a good job of the OHE. You've scaled, and part of scaling is removing that extrinsic stain. So there's very little stain and biofilm left on the teeth. So you shouldn't have to be using your prophy paste to remove a lot of this. Curettage involves the removal of diseased lining of the soft tissue pocket wall. Okay, and that's called soft tissue debridement, including the junctional epithelium and the underlying inflamed connective tissue. So you are opening up your curette. You're not trying to keep that curette towards the tooth. You're opening it up to 90 degrees or greater, or basically what you're doing with a Gracie, an area specific, is you're using the other end of the area specific. So the blade is against the tissue. And then you place lateral pressure on the outside of the gum tissue, and you're scraping that tissue from the lining of the pocket. The theory is that by removing all that inflamed tissue, as well as the necrotic and granular tissue, and removing that junctional epithelium and getting some of that suprabony pocket smoothed, it's going to allow healing. Now, this is not an accepted procedure anymore. I learned how to do curettage. We do coincidental curettage. Every time you put your instrument in a sulcus or a pocket and you bring that instrument out, there's going to be a little bit of lining of the gum tissue along with it. But we're not purposely curetting the lining of the gum tissue anymore. There's still codes for that though. So we're doing periodontal debridement, and that's the treatment of inflammatory periodontal disease. We've evolved. We're not just scaling and root planing. We are focusing on the soft tissue response. So inflammatory periodontal disease is a group of inflammatory diseases of the periodontium, including gingivitis and periodontitis. So we know gingivitis is a periodontal disease. It's just the only reversible state. Our goal is soft tissue healing, and that's a natural process by which the body repairs itself after bacterial debridement or surgery. Now that bacteria is going to adhere to any surface, rough or smooth, so that biofilm is going to recollect. But if we can keep things cleansable on a regular basis for the patient, soft tissue healing can be achieved. But it's a natural process. So a lot of times we want to do our 4 quadrants or 6 sextants of debridement, check for healing before we start talking about laser therapy, Arrestin, putting the antibiotics underneath the gum tissue, and those other adjunctive therapies. Well, let's see what the body can do. And then instead of it being a generalized situation, it might just be a localized situation. So periodontal debridement is the mechanical non-surgical therapy consisting of oral hygiene self-care. It's not just what we're doing in the chair, it's what the patient's doing on a regular basis, as well as periodontal instrumentation, and it's intended to prevent, arrest, control, or eliminate periodontal diseases to ultimately maintain the teeth in a functional state of health. Functional state of health. Might not be ideal. You're not going to be able to get maybe an 8mm pocket down to a 3mm sulcus, but that's okay. If they can maintain a 5mm pocket through what they're doing in irrigation and that type of stuff, if they can maintain it, that will be a functional state. So periodontal debridement remains the foundation of non-surgical periodontal therapy. That's what we do each and every day. So combined with the oral self-care, as well as what we're doing with the periodontal debridement, we want to see the reduction in clinical inflammation. We want to see an establishment of more beneficial microorganisms, and without a phase contrast microscope, we don't know that. We want to see less pathogenic microorganisms, a reduction in probing depths, and gain in attachment through that long junctional epithelium. So we are reprobing, we are reassessing. We might not know the beneficial versus the non-beneficial microorganisms, but we want to see that clinical inflammation. We want to see a reduction in pocket depths and a gain in attachment. That is what we do when we are reassessing our patients. If there are specific areas that are not healing, then we need to scratch our head. Is there still calculus there, which is acting as a bacterial trap? Because biofilm is always, always, always on calculus. So is there still calculus remaining? Or do we need to do further investigation into the type of microorganisms that are in that pocket so we can treat this pocket differently than the rest of the mouth? So the rationale and indications for periodontal debridement: self-evident, signs of gingival inflammation, elevated levels of bacterial pathogens, as well as the progressive attachment or alveolar bone loss. Right? We are monitoring all of this with our full perio assessment every time the patient comes in. The purpose, again, is to treat and resolve inflammation in the periodontal soft tissues by removing the irritants, which are the super and subgingival biofilms, as well as calculus. So the ultimate end goal is the preservation of form and function of the dentition. How do we do that? All right, what you do each and every time with each and every patient. You're taking probing depths, you're checking the clinical attachment level, alveolar bone height, you're looking at the radiographs, bleeding on probing, visual signs of inflammation, and hopefully changes in the subgingival microbiota. So we need to go to the science to show us how long does that microbiota subgingivally turn pathogenic from the time that we have thoroughly debrided that area. And that will guide us to how frequently does that patient need to come in? Are they able to reach the pocket depth with a water jet device and with chemicals? Or do they need to rely on us? So some patients might be a 3-month, some patients might be a 2-month, some patients I've even had come in every 6 weeks until we can get them under control. So our outcomes, we've discussed. Okay, root planing teeth with initially shallow probing depths with less than 3 millimeters, slightly decreased or did not alter the probing depths, but clinical loss of attachment did occur. So we don't want to be using a working stroke and over-instrumenting our patients. You are then labeled as the heavy-handed hygienist. I don't want to see Jane again because she hurts, right? If there's no calculus there, we're de-plaquing with our instrument. We are not removing calculus and placing a lot of lateral pressure on that tooth and root surface. So we need to be careful when we're working in that subgingival environment that we don't hurt that clinical attachment level, because science shows us if we are heavy-handed and we're every portion of every tooth, we can cause damage. So the number of gram-negative microorganisms when we're doing periodontal debridement does decrease, especially those spirochetes. Those spirochetes are bad bugs. We want to see a number of the gram-positive rods and cocci increase. Now, if they've got the AA, the agrigobacter, okay, they may still be present because they're the ones that invade the soft tissue, and you're not going to see tissue response with that. So that might be an area where it's not responding adequately. So, gee, do we need to do a BANA test? Okay, and that's the one that you can do chair side to check to see if there are red complex microorganisms, and it tells you how much of, but it doesn't tell you which red complex. Or do we need to do a DNA test to see specifically which bacteria is there? And with those DNA tests, they can also do a antibiotic sensitivity to see which is the best antibiotic for this particular type of bacteria. So that is more advanced, and if you work in Perio, that is what you'll be assisting with. It's really, really cool. Or if you're in a practice that does soft tissue management, really, really cool. Back in the 80s when I was doing this, we just automatically put everybody on amoxicillin or clindamycin, broad spectrum antibiotic, and metronidazole for the gram-negative bacteria. Automatically. If you were going through root planing, that's what you did. It was overkill. So we're not doing that anymore. We're letting the body dictate. All right, we're looking for reduction of inflammation, bleeding on probing. With the reduction of inflammation, there's an increase in collagen fibers. This allows the reattachment of a long junctional epithelium, and that increases the resistance to passage of the probe tip. Okay, if you've got a long junctional epithelium, you've got a thicker attachment than that real thin junctional epithelium that's normally found. So we're looking for a gain in clinical attachment. With that, it's a decrease in the probing depths after your instrumentation because you have an increase in resistance of that periodontal probe. You've got that long junctional epithelium, and that inflamed tissue, okay, is replaced by firm collagen fibers. You're not getting any bone growth. So the treatment sequence, your dental hygiene diagnosis, that's what you're developing after you do your periodontal assessment, okay? Your AAP, your ADA classification, your treatment plan. So your dental hygiene diagnosis is your AAP, clinical, it's going to be gingivitis on a reduced periodontium, let's say, as evidenced by, okay, and that makes it a dental hygiene diagnosis, as evidenced by. Then we come up with the description. The oral hygiene self-care instructions are specifically designed for that particular patient. If the patient has type 1 embrasures, dental flossing is going to be great. If your patient has type 2 or type 3 embrasures, dental floss does no good. They need a go-between, a proxa brush, they need a water flosser, they need something else besides the string floss. So string floss is really only beneficial on type 1 embrasures. It's not the end-all to beat-all anymore. 9mm pockets, generalized 9mm pockets. I was still, when I was a student and a new grad, if you weren't flossing, the disease is going to get worse. Well, dental floss only gets 3 to 4 millimeters subgingivally. And if they've got an open embrasure space, it doesn't clean those concavities of the tooth surface or root surface. So you need something to get into those concavities, and a brush will do that. Do they need topical or local anesthesia for their debridement? Right, so that also goes into your treatment plan. It only needs to be listed once, but for local anesthesia, it needs to be listed on your treatment plan. After treatment of care, maintenance visits are required to monitor. Do you need them back for a perio reeval 6 weeks later? You get a point for that. So if there's bleeding in perio, bring them back. It's an easy point. It only takes one visit, right? Plus, you want to see how the patient is responding before you send them off for 3 months, 4 months, whatever. Any questions so far? Your hygiene faculty can do local anesthesia. Some hygiene faculty is more comfortable than others. So it's not uncommon if you need local anesthesia that your instructor working with you might say, can you ask so-and-so?
I have a question.
Yeah.
Sorry. You said that if they have, is there a certain amount of bleeding on probing they have to have for us to do a perio reeval?
They have to have inflammation, 30% or more.
Okay. And you can bring them back in just a week?
No, 4 weeks.
Oh, okay. All right. So 4 weeks after, if they have a lot of inflammation and it's just a one appointment thing and all you do is probe them again?
You do a complete perio assessment.
Okay.
Including a plaque index, and then you can de-plaque them and send them on their way. Sometimes if there's no resolution and there's a lot of still residual calculus, you've got a patient that's a difficulty 4 that hasn't been to the dentist in 15 years, you are not going to be able to get all that calculus off. It's impossible in your appointments. You have to, you do the best you can where you think you've got it all off. Then they come back 3 months later, and instead of being a difficulty 4, hopefully they're a difficulty 3, hopefully a 2, but they're not going to be clean, guaranteed.
Okay. All right. I guess I didn't know that. That's good to know. Yeah. Great. Thank you.
So we only have, I think, 1 or 2 weeks in between this semester and the summer semester. So you can bring somebody back if you're continuing to see them. If you've completed treatment and another student can't see that patient for a periodontal reeval because they don't know what they're looking at. They don't know, I mean, we've only got the written word. Does that make sense? Okay, so the treatment sequence, there are different types of local and topical anesthetic. We have different types available in school. One of them is lidocaine topical. That's what we have. It's an amide. You're going to get into this more next in the fall when you have local anesthesia, which is a fun course. But anyway, it's 5% lidocaine. It tastes awful, but it works. Benzocaine is what most offices have. That's an ester type. Some patients are allergic to esters. And benzocaine is usually 20%. There's Orachix, which we do not have currently. And that's a combination of 2.5 Lido and 2.5 Prilo. Then you also have Ceticane, and that's what we currently have. Ceticane is benzocaine 14%, butaben 2%, and tetracaine hydrochloride 2%. So when you are using topical anesthetic, we're not just saying topical used. We're not saying Ceticane used. We are writing down Ceticane topical used, upper right quadrant, and then we're listing the percentages. Benzocaine 14, butaben 2%, tetracaine, HCl 2%, 14, 2, and 2. Orachix is 2.5, 2.5. You will have this memorized, but you need to list this. Private practice, do you do it? Heavens no. But by listing it each and every time, guess what? By the time you're ready to take your boards, you know this. It's in long-term memory. So best results are obtained when a small amount is applied on a cotton tip applicator. The tissues are dried prior to the application of the agent, and the applicator is held in contact with the mucous membranes for 1 to 2 minutes. Now this is especially when you are doing local anesthesia afterwards. So you have a patient that doesn't need local. They're sensitive to probing but want something. What are you going to do? You can't numb all 4 quadrants just to get your probing done. Well, we've got the lidocaine 5%, and we've got the Ceticane. The Ceticane is nice because it's a liquid, and you get this tiny little blue tip with the plastic tip that you can squirt that liquid underneath the gum tissue, and it's almost an immediate effect, and it lasts for about 45 minutes. The lidocaine is a paste or a gel. You can put a little bit in a dappen dish and actually place your curette into the lidocaine and place that, or the benzocaine, and place that subgingivally, and then go back and probe or instrument. So that's how you get the lidocaine and benzocaine subgingivally. Orachix is great. It's really expensive. So if you're only doing 1 to 2 teeth, if you only need 1 to 2 teeth, you have to use waste an entire cartridge of the Orachix. We might recommend let's numb them up. Let's do an infiltration. But whenever you're using topical, you want to dry the area first because we don't want a lot of saliva diluting the topical. We want it to be touching the tissue. A little bit goes a long way. There could be an allergic reaction. Ceticane spray, we have this for radiology. Most offices don't have Ceticane spray available. I particularly love it in my office. I always ordered it because occasionally you want it. Just 1 squirt here, and you press down this here. It just presses down. It tastes awful, but the patient will then rinse out afterwards, and they are numb. You can take radiographs. There's an anesthetic patch, which is not really used anymore. There's electronic anesthesia. These topical sprays need to be used very judiciously. okay, because the patient can swallow them and it can get in their circulatory system. Local anesthetic is best applied by quadrant or by sextant. We will only do one quadrant or sextant at a time. We've been in a situation where we have anesthetized 2 quadrants on a patient, and guess what? You were only able to complete 1. So we put that patient through an injection as well as injecting medication into that patient where it wasn't needed. So we recommend you always do one side and then do the other side. You do one side, patient will then be able to chew and use the non-tender side or non-numb side, right? So you're not doing the entire maxilla, because if they come back and they need anesthesia, you cannot do a block on the mandibular right and the mandibular left at the same time, and oftentimes even at the same day. So try and do one side and then the other. You don't always have to start on the maxillary right. You can start on the mandibular left if you want, but then you go to the maxillary left. So before debridement procedures start, it's necessary to obtain written informed consent. That's your treatment plan. You want to explain the procedures, especially if somebody is caked with calculus, that they are going to feel spaces between the teeth. It might feel like I'm removing part of your tooth, but I'm not. You're showing the patient with a mirror, this is what that calculus is. I need to remove that. There might be some tissue shrinkage, which increases height sensitivity. Your root surfaces might be sensitive, so I'll be giving you a special toothpaste to take home. Because if that tooth structure, that root structure has been encased with calculus, it's going to be sensitive to temperatures. And there might be, with your periodontal reevaluation, there might be other procedures that you're going to recommend. Subgingival debridement, calculus removal. The primary goal is to remove calculus deposits from the supragingival and subgingival tooth surfaces. You want the subgingival debridement to render a surface free of biofilm, calculus, endotoxins, to enable soft tissue healing. So that's the key, to enable soft tissue healing and render function back. It is impossible to remove 100% of the calculus. Impossible. So total root surface, total smoothness of the root surface is not adequate or needed for tissue healing. We do the best we can working in that closed environment. Okay, we do the best we can. If periodontal debridement can achieve elimination of inflammation and halt disease progression, then we don't need to treat any further. If it fails, if there's still inflammation, all right, we might need more definitive debridement. We might need more diagnostic testing. Chemotherapeutics might be needed, as well as periodontal surgery. So we know that the subgingival gram-negative microorganisms release these endotoxins, or the lipopolysaccharides, from their cell walls. And these endotoxins are toxic compounds that are capable of penetrating that junctional epithelium as well as entering the connective tissues. The end result is destruction of the periodontal tissues. So endotoxins activate the inflammatory or immune response. They cause loss of connective tissue attachment from the root surface, apical migration of the junctional epithelium, and bone loss. Apical migration of junctional epithelium is periodontitis, non-reversible. The periodontal pocket forms and the cementum becomes exposed as well as contaminated. Then you've got necrotic or contaminated cementum, and that is really the porous cementum that contains the endotoxins as well as biofilm and calculus. So by removing the calculus, we're trying to smooth out that root surface so there's less bacterial contamination. Endotoxins found on diseased root surfaces are weakly and superficially bound. This is important, my friends. They're weakly and superficially bound. Therefore, 99% of endotoxins may be removed by brushing. This is a totally different philosophy than when I was a student. That's why we were root planing. We were getting all that cementum off. But guess what? They're loosely bound. So periodontal therapy is the treatment of the periodontal lesion. The key is to remove biofilm and calculus to reduce the number of oral bacteria below the threshold, all right, capable of irritating and initiating inflammation. The therapeutic goal of debridement therapy is to control the bacterial infection. This is up to the patient. What are some of the adverse effects of periodontal debridement? You may cause hypersensitivity because we're exposing dentin. It may take 3 to 4 days, to be initiated. So we want to have the patient aware that there might be hypersensitivity and be aware that they need to do certain things to limit that. Okay, use this toothpaste. It takes at least 2 weeks for that potassium nitrate to do its work and that fluoride to start hardening those root surfaces. So they need to know that might be one of the symptoms. The deeper the pocket, the less accurate our scaling is. If it's over 4 millimeters, it is a shot in the dark. Furcations, what's the root anatomy? Can we even reach this area? How much time do we have? And clinician skill is key. So what's the pocket depth? Do we have the appropriate instruments for the pocket that we're working in? Are you using a regular, brand new instrument, or are you using a mini or micro after 5 curette? The mini and micro have a really tiny, tiny little blade versus the regular. Is it a long, shallow pocket or not? Furcations are horrible. Our instruments are so big, we cannot adequately get into the furcation areas. So that is where our ultrasonics really come in. Know your anatomy. Every hygienist is going to have a different skill set. And we have to recognize that, and we have to also appreciate that. We are all doing the best we can. We're going to be in private practice. You're going to see a patient that Susie has seen for the last 4 times, and you're going to dread knowing you're going to have calculus all over the place because Susie's not a good scaler. It's not that she doesn't want to be a good scaler, she just doesn't have the technique. And then the patient's not going to like you because Susie never did it this way. Susie never hurt me. Susie was always done in 20 minutes. So you have to educate the patient. Well, this is how you're presenting yourself today. This is this is what I'm finding, without saying Susie doesn't know what she's doing. All right, so we're looking for decrease in probing depths. And we don't want to overtreat our patients. We need to allow the body to heal. So once we treat one quadrant, if the patient's coming back from a Monday to a Wednesday, we're not going to go in and rescale what we just treated on Monday because we have to have healing take place. So once periodontal debridement occurs, an initial inflammatory action occurs because we've disrupted everything and we've gotten this big blade in there and we've caused even more ulcerations. But the inflammatory process the acute inflammatory process will resolve in about 24 hours and then tissue healing can begin. So healing after gingivitis, when dental biofilm and calculus is removed, the pocket develops a new junctional epithelium. That long junctional epithelium is going to form. Color, contour, consistency, it's going to take place and resolve, and within about 4 to 8 weeks, there is going to be complete tissue resolution. Gingivitis, it's going to look like it resolves more quickly than cellularly resolves. For periodontitis, once the dental biofilm, calculus, and that necrotic cementum's been removed, healing then can start. Healing occurs and a long junctional epithelium forms. The damage that's been done cannot be undone. The damage to the bone. Okay, that alveolar bone and the PDL fibers will not be restored without surgery. The same healing that occurs in the gingiva will also occur in the periodontal unit. The pocket is no longer a pocket, and a long junctional epithelium may be present. So that junctional epithelium will be present within 1 to 2 weeks after initial debridement, with the greatest reduction in probing depth occurring at 4 to 8 weeks. So when you bring your patient back for a perio reeval, it's after that 4 weeks, 4 to 8 weeks, that patient can come back. Does that make sense? We don't want you interrupting that junctional epithelium before then. So we have this reevaluation 4 to 8 weeks afterwards. You are going to be doing a complete periodontal assessment on your patient. If biofilm control has not been established, that subgingival bacteria can repopulate with about 4 to 8 weeks. If initial therapy shows improvement, but there's still 5 millimeters or greater of pocket depth, then the patient should be placed on a periodontal maintenance and should return to the dental office every 2 to 3 months. What we're trying to do is stay ahead of the damage that the pathogens do. So that's where this 3-month maintenance, perio maintenance came up with. Okay, we'd love to see them every 8 weeks, but that's not always possible. So after 8 weeks, the pathogenic bacteria is starting to repopulate, and before damage can be done, okay, that gives you another 4 weeks. So that 2 to 3 month recare is again to stay ahead of the damaging pathogens. Some patients might need to be on a 2-month, some patients might need to be on a 3-month. Then the unresponsive areas can be closely monitored for signs of further attachment loss. Persistent inflammation may result, and it usually results from incomplete debridement, patient noncompliance, or some sort of systemic disease. So now we've got these endoscopes that some offices have, where we can actually go in and take a look at that subgingival environment and see where the calculus is missing. Ultrasonic versus hand instrumentation. The two have been compared, and depending on what studies you look at, there really isn't any substantive difference. The advantage of the ultrasonic is that you are lavaging while you're doing it, so it really does help with the bacterial flushing out. Some of these ultrasonic inserts can reach the long, narrow pockets better than hand instruments. Both will burnish calculus. So it's important to remember that using the ultrasonic or hand instruments, that post-treatment needs to be evaluated to make sure that there's tissue healing. Whenever you use an ultrasonic insert, unless you're doing specific techniques that you are taught, you have to follow up with hand instruments. Lasers, we have lasers in the clinic. Okay, we are allowed to, in the state of Virginia, to use a laser. We can use a soft tissue diode laser that is uninitiated. Okay, it's not meant for cutting. And we're doing a bacterial decontamination with it. You're going to learn that this summer. Results, a little bit, studies are still saying, oh, it's not the best thing. It's not going to cure anything, but it's, again, trying to kill the bacteria. CO2 laser is the best for soft tissue incision, chronectomies. There are lots of different lasers out. We are not allowed to use them. We are only allowed to use the soft tissue diode laser at a certain wattage. Healing response has been shown to be very good, as well as attaining a soft, long junctional epithelium. There's something called guided biofilm therapy. Now that is, think about a Prophyjet that you've had, the baking soda and water, and it sprays all over the place, all right? And you're not supposed to direct it underneath the gum tissue. Well, they've refined this, so now you're using glycine or erythritol powder, and there's a specific tip, and you actually place this angling towards the gum line area. So it's called guided bacterial therapy. We have these machines in at Nova, but what we can't do is use them yet because of COVID. Once this pandemic has been lifted, we can teach you how to use it, but it is so cool. It comes out with much less pressure and much less grit, because the glycine and erythritol are very, very fine powders. It doesn't spray all over the place. It's good for bacterial decontamination subgingivally. It's wonderful around implants, as well as ortho. Because the powder is finer, it's not that great for removing stain like the regular Prophyjet is. But it's GBT, okay, is what you'll see, guided biofilm therapy. Really cool. So we want to use science as a basis for what we are recommending for our patients. We want to, again, the primary goal is to make the root and soft tissue biologically compatible, to make things as healthy as possible. Periodontal debridement improves the tissue by decreasing both the gingival inflammation and the probing depths by creating that long junctional epithelium. It takes 4 to 8 weeks, providing the patient is compliant. Healing is considered complete after about 3 to 6 months after final instrumentation. So you want to keep that patient on a very close maintenance procedure. Let's get a couple questions. Which clinical presentations may be expected in a patient after periodontal debridement? And it is the long junctional epithelium. Thank you, Jasmine. Now, why can't you do that if this was on the test? You know what Jasmine would do? She'd pick another thing.
100%. I'm tuning in extra hard for this, okay?
Once healing from periodontal debridement has occurred, what is expected? You are on a roll today, Jasmine. Plus, she's the only one with enough courage to say something. Bone and periodontal ligament fibers cannot be restored following alveolar bone loss. This is one of those where I would be able to rationalize each and every one. Is it true? Well, it really is. They can't be restored. Okay. But you can have surgery to help restore them. You're looking for that long junctional epithelium. Successful periodontal treatment and regeneration of periodontal tissues depends on the removal of the super and subcalculus. True. Thank you, Mary. She's chiming in. Healing is considered complete after 3 to 6 months. Oh, Kylie. Now, Kylie, you're not Kylie. Are you ever going to get this to a healthy state? You might. A resolved state is when you've got the bone back. You're never going to get this resolved. Look at this mucogingival defect here. Now, is flossing going to help that patient? Not at all. They need a big, thick bottle brush type of proxa brush in there.
Misty, I have a question.
Yeah.
So when we have patients like this and when we remove the calculus, we might experience the tooth to be loose, right? Because that's sometimes that could be supporting the tooth.
Those, yes, those, and tooth mobility is oftentimes expected to increase, especially after periodontal surgery, because they're affecting the bone, and then that will hopefully help tighten up. You will have patients where, for example, if this was just soft tissue and very little bone around here, and we don't know how long these roots are, and this was caked with calculus, that calculus is almost acting like a splint. So
Yeah.
we will tell you not to scale that.
So in real practice, though, do we need to have the patient sign some sort of consent, or that's just part of the OHE?
No, there's usually consent forms for periodontal therapy to say that they've been informed, and that's all part of the treatment plan. They've been informed they have periodontal disease. They've been informed they need this. They've been informed that the teeth might be mobile. They've been informed teeth might need to be extracted, blah, 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 blah.
Okay, thank you.
Yeah, periodontists have all of that depending, and some of them have treatment plans. So this is a stage 1, stage 2, stage 3, stage 4, and then you pick up that packet for that particular patient. But that's all part of the assessment and consultation with the patient. As a hygienist, I'd have a real hard time not scaling these, but you do have to remember that sometimes it's acting as a splint. We are in a dental hygiene school, so if something happens where the patient loses a tooth because we've scaled around it, we don't have any recourse to send that patient for treatment. If we were in a dental school, we'd send them to the dental students. Here we don't. So we leave well enough alone and refer them to a periodontist. Okay.
Can you still treat them though?
Oh yeah, you would treat everything that's treatable. You might be not able to scale these mandibular anteriors, and there might be 1 or 2 teeth, especially if there is an abscess, an apical abscess. You're not messing with that. So you're going to stay away from number 3 and number 19.
Okay.
That's all part of the Perio assessment, and that's one reason also why Dr. Vamuri and the dentists want to see some good radiographs when they come in for hard tissue. Okay, that was a longer chapter than I thought it was going to be. Let's take a 5-minute break, and we'll come back.